Good evening. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge topics to the medical community of Staten Island and throughout New York City and the tri-state area. We're going to talk about endocrinology, a fancy term, one of the medical subspecialties of hormone treatment. And hormones have a lot to do with how you feel. That feeling that you have, if you're hyper, not hyper, if all kinds of things. And we have a wonderful expert in endocrinology here today. This is Dr. Philip Otterbeck. He's the chairman of the Department of Medicine at Richmond University Medical Center, which I'm privileged to be involved at. I'm the chief of neurology over there. And he's the head of the division of endocrinology. And we're going to talk about hormones. We've had, in the past, a wonderful talk about diabetes. So now we're going to talk about some of the other hormone issues and the idea about what they do to your body and what we could do and what's new about them. So tell us a little bit, what's an endocrinologist?
An endocrinologist is a subspecialist of internal medicine who practices and understands and treats diseases of the endocrine system. Specifically, that's the organs that produce hormones. So then that kind of can be a nebulous term. What are the hormones of the body? What organs do we treat? In our brain, we have a pituitary gland. On our neck, we have our thyroid gland. In the body cavity, we have the adrenal gland, and of course, the male and female gonads, the reproductive organs, testes and ovaries, are all part of the endocrine system. They make hormones, and those hormones are basically chemical messengers that go to all around the body, bind to receptors, and cause the body to do one or the other action.
So let me ask you about hormones. And I think as a neurologist, I'm always impressed by how signals go from the brain to different parts of the body. I can move my finger quickly. People could play the piano. I could speak as quickly as I am from my origins in Brooklyn, but now living on Staten Island. So tell me a little bit about hormones. Hormones seem to be able to change your mood, what happens to you very quickly. Tell us a little bit how it circulates and how quickly these things happen.
Changes in the hormonal system can happen almost immediately. When we get upset, when we have a stressor in our lives, the body immediately secretes adrenaline. Adrenaline is responsible for the fight or flight response that I'm sure everybody remembers from their high school biology. Yes. And so really the effect can be immediate. The adrenal glands release that hormone, and that hormone immediately goes into the bloodstream and binds to receptors all around the body. And the thyroid is another example. The thyroid gland, of course, sits in our neck, and it has receptors from head to toe. So in order for a hormone or a gland to have an effect in a distant way, that is where the effect is not right next to the gland, that hormone has to travel in the bloodstream, get to the gland, get to the other location, bind to receptor, and that receptor will tell tell its organ system what it needs to do, and those receptors are head to toe.
It's amazing how this could happen in a matter of a few seconds.
Yeah.
So we mentioned the thyroid. Mm-hmm. So we're going to sort of jump around different systems of the body.
Sure.
And the thyroid is a big one. It's one of the most common of problems that people have. In my practice as a neurologist, I see a lot of patients on thyroid replacement therapies. So how do you put together, I know you teach residents, we teach medical students, how do you describe the thyroid? There's too much thyroid, there's too little thyroid, there's just the right amount. It's sort of that Goldilocks approach. How do people feel with it? Maybe give our wonderful audience a little bit of an idea, to our viewers. If you're feeling tired for a few weeks, does that mean your thyroid's not good? If you're gaining a few pounds during these stressful times, is that because your thyroid is not good? If you feel a little anxious or hyper, does it mean that your thyroid is too active? And I think knowing when to check it, or should we check it routinely, is something that is something that's hard for us to know as a patient. And then I'll ask you as the endocrinologist, tell us about your thyroid a little bit.
Thyroid is a butterfly-shaped gland in your neck, kind of like right over here, that you can see underneath my tie. And this organ releases a hormone called thyroid hormone. Now, as you pointed out, you don't want too much, you don't want too little, you want it to be just right, to use the Goldilocks reference. So now, the thyroid, like any organ system, can be sick. It can make too much or too little. If it makes too much, it can give you a variety of symptoms. If it's too little, it can give you a variety of symptoms. Just as an example, the more common one, hypothyroidism or slow thyroid, that is a thyroid that does not make enough thyroid hormone, that can make a patient feel tired, constipated, cold. They can complain of hair loss, very dry skin. Whereas a patient that is hyperthyroid can have the opposite. They can feel anxious, they can feel jittery, they can feel like they have too much energy, they can lose weight. So either one is not ideal and must be managed appropriately so that the patient are right in the middle, having just the right amount of thyroid hormone. Now the question is how you get there and how you do that. I'm sure we'll talk about a little bit about that. But the question of whether or not, if you have those symptoms for a day or a week, does everybody that has a symptom, does that mean their thyroid is off? You know, as I mentioned, if you have a slow thyroid, you could feel tired, but the answer is not everybody who's tired has a thyroid problem. So if you have a persistent symptom, the ones that I mentioned, speak to your doctor about it, speak to your provider about it, because the thyroid testing is as simple as a blood test. The doctor can check a hormone in the blood called a TSH, and that will tell the doctor very convincingly whether a patient has hyper or hypothyroidism. And it's all it is a blood test. So if you have symptoms that could fall into one of those two buckets, yes, speak to the doctor and ask to get that tested.
One of the things that people are most concerned about their thyroid is that it's a butterfly gland in your neck, is the term goiter. Mm-hmm. And I mean, we in medical school, and sometimes people have seen pictures, there's always the picture of someone who has this huge goiter. Thank goodness we don't see that much anymore. Tell us about that term, and nodules, and maybe another word. I don't know if they're actually synonyms, but the nodules that people sometimes are picked up on various testing that people do, or they feel something like a bump in their neck. And how worried should people be if they feel something in their neck?
If you feel something in your neck, a bump or a lump that shouldn't be there or wasn't there before for sure, that's a time that you do need to speak to your doctor, because that bump in your neck, it might not even be the thyroid, it might be a lymph node, it might be a muscle, it might be something else, it might be a cyst. So a proper medical evaluation plus or minus a neck ultrasound probably would be indicated for a patient in that scenario. The term goiter, though certainly people have seen those pictures with the people with goiters or thyroids that come out to here. Of course, those are very scary pictures. As you said, we don't see that much anymore, and the question is why? Well, people that really get a big goiter like that are people that tend to be in an area where they don't have iodine in the diet. Everybody knows that when they go to the store, they see the salt, and they see iodized salt. The government has tried to make sure that there's the appropriate amount of iodine in the salt so that we don't get goiters, at least like that in this country. But goiter, the term itself, just basically means a big thyroid. Now, there's a variety of reasons that thyroids can be big. Some of them can have autoimmune problems where there's some inflammation of the gland. We call that Graves' disease or Hashimoto's disease. Some people can have a big goiter just because it's big. Some people have big hands, some people have big thyroids. And some people grow nodules on their thyroid gland. Nodules can be, they're basically lumps or bumps on the thyroid gland. Now, nodules are important to know about because nodules can be either benign or cancerous. And of course, patients, doctors like to know what nodules are important, that is benign, that is cancerous, or unimportant, that is the ones that are benign. So when we do an ultrasound of the neck, we examine the tissue of the thyroid gland, and we're able to see a lot of things on those pictures. We're able to see if it's a healthy looking tissue. We call that homogeneous echotexture when it's healthy looking, or heterogeneous echotexture when it's sick looking, and could mean that the patient has some autoimmune problem of the thyroid. But we're also looking for those lumps, those bumps. If we see those lumps and bumps, that is the nodules, then we say to ourselves, well, are those concerning looking nodules or are they benign looking nodules? And if there's a particular concern, if they're really big or they have calcium deposits, calcifications we call them, or there's a lot of blood flow through the nodule, we call that vascularity. Those are the nodules that we would go ahead and do a biopsy for. And I know biopsy is a scary word, and it kind of makes us worried about, oh my God, I'm going to have a surgery and a procedure. Biopsies are very simply done in the office. We lay the patients down on the table flat. We put the needle in 2 or 3 times, get an adequate sample, make some slides, and send it off to the pathologist for review. 95% of all nodules are benign, thankfully. 5% of the time, unfortunately, patients do have thyroid cancer.
You mentioned Graves' disease.
Yes.
And autoimmune diseases could do a lot of things. And autoimmune diseases occur mostly in women. And that's why I think thyroid disease is more commonly in women. Now, we watch television, and on television we see a lot of commercials. And commercials sometimes give us a little bit of an inkling of information of what we look at, what our viewers look at. And we see patients, and there's a woman I see on TV whose eyes are protruding. And we call it ophthalmopathy or whatever, we use some medical terms for it. And as a neurologist, I mean, protruding eyes mean a lot to me also. But they say there's a new medicine out there for this condition. Maybe you can just describe a little bit, because especially thyroid medicines we'll talk about in a few minutes. But I've seen people's lives changed or affected actually in a negative way by having very protruding eyes. And there are different words for it. Maybe you can go into that a little bit. And what causes that? Is something pushing out the eyes, or is it something else that's happening, areas of inflammation? And how does this new medicine work? And is it really an effective agent, or is it something that we're just seeing on television that really isn't working that well?
It's a great question. These patients, this tends to happen in people that have Graves' disease. Now, what is Graves' disease? I mentioned a little while ago. Graves' disease is when you have antibodies that bind to the thyroid gland and stimulate that thyroid gland. And so that makes the thyroid gland secrete too much thyroid hormone. That thyroid hormone goes around the body and causes what we talked about before, hyperthyroidism, can give a patient a lot of symptoms that we discussed. Now, one of the other manifestations of Graves' disease is that patients could have the bulging eyes, as you discussed. And this can be a big problem for our patients, because not only is there a cosmetic concern, people, that bulgy eye thing can be particularly disturbing to a patient, but also it causes the patients a lot of distress. The eyes get very sandy and red, and people really have some significant trouble all day, every day, rubbing their eyes, and of course that exacerbates the problem. And we do have some approaches to this. We give them artificial tears, we give them drops to put in the eyes, but it does not generally solve the problem. Years ago, really the only treatment we had to offer patients were high doses of steroids, prednisone and others. The problem with those medicines is they have a lot of negative side effects on the bones. They cause weight gain, high blood sugar, diabetes. So, of course, that was a suboptimal approach to these patients. And then in patients that failed steroids, we had surgery. They literally the surgeon had to literally go in, decompress the area, and remove some tissue so that the eyes can go back in the socket and certainly help out the patient. The other problem with this, from a symptomatic standpoint, was that patients were getting double vision. So many of my patients in the past really struggled with this, and they had to give up driving because their ophthalmopathy was so badly controlled, because there were very few options for therapy. What happened with this new medicine that I'm sure a lot of our patients in the audience are seeing on TV is a medicine called Tepezza. Tepezza is a monoclonal antibody, and it goes against a monoclonal antibody against the IGF-1 receptor. I know it's a fancy word,
yes,
fancy term, but basically what that does is it enables the eye to move back into the socket, decreases all that tissue and that inflammation, and it actually is quite efficacious. When you look at the study, about 71 to 83% of patients had a significant clinical response to the medication. So this is a very highly efficacious drug, generally well tolerated, and it certainly did not have all the risks of surgery as well as the side effects of something like prednisone therapy.
So if somebody maybe before the pandemic and had this bulging eyelids, we use the word proptosis or exophthalmos, and use the word ophthalmopathy, which is ophthalmos, just eye problems. So these are all synonyms of really what we're seeing. So if someone has had bulging eyes because of Graves' disease, And they might not be as up to date or might not have gone to their endocrinologist or a physician in a couple of years. Is it something that could work even if they've had this for a number of years?
Absolutely. So if this has been a persistent problem, you've tried other therapies without success, this is the patient that really should be considered for this kind of therapy. Yeah.
So I think that's so crucial to tell our audience that these medicines are available right now, that there are new things that are coming out. And when new things come out, we really need to know. Because if we don't jump on board, you can go another 2 or 3 years before you figure it out that, wow, this is something that's there. I always believe that patients are empowered by information. So I love when someone comes into my office and says to me, what do you think about this new medicine? And most times I know, sometimes I'll admit I don't know what that is, and I look it up. I go into the computer and I say, wow, that's an interesting medicine, whether by that name or by the brand name or the generic name, and we see if it works for you, and we might see if it might be a good choice. So here with this not even an unusual disorder, but something called Graves' disease, which we see not uncommonly, all of us have seen patients with bulging eyes from this, and even people on TV. And the idea that this might be something beneficial, I think, is so important.
And one of the things, Dr. Perel, that I think is very important with this, if the doctor does tell you you have Graves' disease, one of the risk factors for developing that eye disease is actually smoking. So if patients are smokers, I would always tell patients to quit smoking, but separately for this condition specifically, if you have Graves' disease, smoking increases the risk for that eye disease. So please try to stop smoking.
Let's talk about thyroid medicine. Everybody remembers the brand name Synthroid, now L-thyroxine, generics. Tell us a little bit about it. Is there anything unique about it or special about different varieties of it?
There are a few brand thyroid hormones that are still on the market. All of them, the main component of them is something called levothyroxine, which is the generic name. And of course, each brand has different fillers, different components that make it a pill, right? I always tell patients that medicines have 2 parts, the active medicine and the thing that literally make it a pill. And different brands have different components of that stuff that make it a pill. And Synthroid is a brand that's been out there for many years. There's also other brands. Unithroid is another one. Tirosint is another one. Again, the main component, the medicine is the same, levothyroxine, but the components are different. So some patients tell me they tolerate one over the other. Some people believe they have some side effects to some of the components of generic brands or one of the other available brands on the market. So in those cases, we simply switch the patient to a different one. The ones that I mentioned, the levothyroxine-based components, they have T4 in it called thyroxine. This is the inactive hormone, and basically what we ask patients to do is to take that pill and let the body convert T4, which is the inactive hormone, to T3, which is the active hormone. Some people prefer to take desiccated pig thyroid hormone called Armour thyroid. That's the brand name. And basically it is pig's thyroid ground up and put in a pill. The difference is with those patients is that pill that they have has 2 components, T4 and T3. T4 being the same inactive hormone as before, but T3, which is the active hormone that they're taking from the outside. Some people feel that medicine works for them better. We try different things for people that maybe aren't feeling up to where they want to be. And really, I have no objection to it so long as the thyroid blood tests remain within the normal range.
Okay. We're going to jump. We're going to jump to another topic.
Okay.
And we're going to talk about osteoporosis. So many of our patients are taking medicines for osteoporosis and are worried about their bone health, and rightly so. Thank God we're living longer, particularly women, and we'll talk about why osteoporosis is more common. There's all kinds of scans that people are going through somewhat routinely now, and everybody comes in, and sometimes they have different words, osteopenia, osteoporosis. And I want to, as an expert, I'd love you to explain to our audience like the differences in those words, and who should be worried, and when should we be worried, and when should we talk about different treatments.
Right. So osteoporosis literally means porous bones, right? Osteo means bone, porosis means porous, so porous bones. And bone density is literally, we remember from your high school science days, mass per unit of volume, right? So the higher the mass per unit volume, the higher the bone density. And as a patient develops osteopenia, which is the earlier disease, and then of course osteoporosis, the bones get weaker and weaker, the density goes down and down. And so the question is, who should be worried about this and why women get it more than men? Well, we should all be worried about osteoporosis, and we should all take actions to prevent it. And first of all, how do we do that? Well, one is to not smoke. Smoking is detrimental directly to bone health. And also we need to take adequate calcium and vitamin D. The vitamin D levels can be checked in the blood. Why do women get it more than men? Women get it more than men because women undergo menopause, right? Usually in the late 40s, early 50s, women's menstrual cycles stop. And they lose their estrogen. And estrogen is critical for bone health and bone development. Men, on the other hand, although our testosterone decreases a little bit, it does not decrease precipitously like women. So testosterone also is important for bone health. So the persistence of the testosterone means that men get less problems with their bones than women. And this bone health, this osteoporosis, how do we determine bone health? How do we determine our bone density? There's a test. It's called a DEXA test, D-E-X-A. And that test is actually recommended for all women above age 65, of course, after menopause. And for those less than 65 when they're menopausal, if they have other risk factors, if they are on medications such as prednisone or they have other conditions that predispose them to poor bone health. And once we establish that a patient has osteoporosis or osteopenia based on their bone density, of course, there are ways of treating that.
So tell us, if somebody does have, when the word osteopenia, so that's less severe than osteoporosis.
Correct.
Do those patients require treatment?
Some. So if you look at the data, about 50% of fractures occur in those that have osteoporosis, and about 50% of the fractures occur in people that have osteopenia. So of course we would say, generally speaking, that anybody with osteoporosis should be treated. But if we don't treat any of the osteopenia folks, then we're really missing out because half of the fractures are occurring there. So then how do we ascertain whom we should treat? Well, luckily there's an evidence-based tool called the FRAX tool, F-R-A-X. The audience can look it up and Google it, and they can put in their relevant data if they're interested. But basically, this tool looks at a lot of the patient's demographics. They'll talk about your age. They'll talk about your bone density. They'll talk about whether you have other conditions like rheumatoid arthritis. They'll ask you, does your mom have a history of a bone fracture? And they'll put in these little demographic questions. And at the end of that demographic questions, the computer will spit out a number. And that will give you your risk for a major osteoporotic fracture or a risk for a hip fracture over the course of 10 years. And if that risk for osteoporotic fracture is 20% or above, or a risk for a hip fracture of 3% or above, those are the patients, even in the context of osteopenia, who should receive treatment for their bone disease.
And what treatments are there?
What treatments are there? So there are a variety of treatments. The standard treatment has been the bisphosphonates. People might remember the names of Fosamax, right, or Boniva. A lot of them have been marketed on television for patients. Those medicines are generally given orally. There is one of them that is administered intravenously once per year. Patients, though, as for instance, take a medicine, alendronate. They're taking 70 milligrams of alendronate once a week with a full glass of water on an empty stomach. They tend to be very well tolerated and quite efficacious with respect to improving bone density. But if patients prefer, they can certainly get the intravenous injection. That's been the standard of our treatment, the bisphosphonates. But now there are newer agents. One of them is something called Prolia, which works a little bit differently from alendronate, and it is a subcutaneous injection. It's an intramuscular injection administered every 6 months, and we do that in the office for our patients routinely.
And what does it actually do? It prevents the breakdown of bones. So why would that work?
So there are two main types of cells in the bone, the osteoblasts and the osteoclasts. I know this gets a little technical, but I always think of the B, the osteoblast. The osteoblasts are the bone builders. So osteoblast B builders and osteoclasts break down the bone. And why would you want something to break down the bone? So you need an interplay between these two types of bone cells to keep the bone healthy and strong. One breaks down the old bone, the other one builds the old bone, builds the new bone. And the way the medicines work is they work by inhibiting the bone breakdown, inhibiting those osteoclasts, which are overactive in people with osteoporosis. So when you inhibit those osteoclasts, the bone breakers, you allow the bone builders, the osteoblasts, to come in and fill in and make new healthy bone.
Makes sense. We're going to jump ahead in the last couple of minutes that we have to a more and more common process called polycystic ovarian syndrome.
Yes.
So you talked about the reproductive organs like the ovaries, testes having issues. Here with polycystic ovarian syndrome, we're seeing this in young women, of course, or young women, of course. Tell me a little bit about what you're seeing with these patients. And so many of the patients are coming to me again. Some of them are taking medicines for diabetes that I'm sort of surprised with what they're taking. And a lot of people are very concerned about this with regard to reproduction, with being able to be fertility. So tell me just a little bit in the last minute or two about PCOS.
PCOS is a very common and probably the most common endocrine condition in women. It is a condition where the ovaries have a tendency to make too much testosterone. And what that does is it manifests as irregular periods, but also, you can imagine in a young lady, too much testosterone can do a variety of things. It can cause excess hair growth. It can cause the loss of hair on a woman in a male pattern, which of course is very uncomfortable. It can also cause hair growth around the nipple, below the belly button. So although there is certainly the problem of the irregularity of the periods and of course its consequent impact on fertility, there's also the cosmetic components of it that are disturbing to young ladies. The diagnostic criteria there are three criteria that we use to make this diagnosis. One is irregularity of periods, menstrual cycles. Secondly is evidence of androgenization. That is either high testosterone in the blood or the physical manifestations that I described a few minutes ago, that excess hair. And also, if a doctor does especially a transvaginal ultrasound to look at the ovary specifically, there can be a classic pattern of those findings on the ovaries.
Are there treatments?
Yes. There are two main treatments. One is, well, of course, diet and exercise modification. Lowering the body weight, keeping the patient active lowers the testosterone level and could, in fact, make the patient start cycling normally. But we also have other drugs. Metformin, as you alluded to, one of our diabetes drugs, lowers testosterone and can help the patient cycle again. And birth control pills can also normalize the cycle and affect all of the physical manifestations of the condition.
We could have a whole series on hormones.
That's true.
And Dr. Otterbeck is a wonderful expert in the field, and I want to thank him so much for being here. We could probably talk about all the hormones for a half hour or longer. There's just so much that are involved with it, and they really affect people in so many different ways. I want to thank you so much, and I hope we've educated you a little bit about hormones and where your hormones are and how we all feel. So stay healthy, and good night, everyone.